The Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policy Maternity Staff Training Program. Milk Supply, Session 8. Objectives. A huge concern of mothers as they begin their breastfeeding journey is whether they will have enough milk. This session will focus on different techniques you can apply to help give mothers the best start in creating a good milk supply and putting them on the road to breastfeeding success. All babies are different. Mothers who have experienced breastfeeding may find that the ease of breastfeeding each baby in the beginning is very different. Some babies seem to know exactly what to do and how to nurse at the breast. Others need time to learn. Breastfeeding is a learned skill for both mothers and babies, so the mother may also need time to learn and work through the breastfeeding process with her new baby. This is often a time of uncertainty, and the learning can be uncomfortable, difficult, or even frightening for the new mother. The new mother, who is often tired, may wonder if her baby is getting enough to eat. It is not uncommon for a mother at this point to have sore nipples. Mothers need to be encouraged to rest and advised to call for help if they have questions. Lactation consultants and postpartum nurses are great resources when questions arise. Both babies and mothers' physicians are also resources to whom mothers can turn. In the early weeks, each mother should continue to exclusively breastfeed and do so often. This allows mother and baby plenty of practice with their new skill of breastfeeding. As they work together, they will begin to get it right, becoming more comfortable and efficient with the process. New mothers need to realize it typically takes a week or longer before they and their new babies are breastfeeding well. Mothers need to be told that things will get easier in a few days. One of the most common reasons a mother will give formula or stop breastfeeding is because she feels or perceives she is not making enough milk for her baby. Perceived reasons, which according to studies occur 40 to 80% of the time amongst those who have discontinued breastfeeding, are what the mother is thinking or feeling, yet in reality, breastfeeding is just fine. If a mother is unaware that her baby needs to have small amounts of colostrum in the first few days and needs to feed frequently to drive up her milk production, the mother may worry that her baby is overly hungry and not getting enough. When she then supplements, or worse, is told to supplement by well-meaning healthcare providers or family members, this impedes her milk production. As a result, her milk supply may not become fully adequate, and breastfeeding then will fail. Breastfeeding success hinges on building a mother's confidence. Giving her concrete signs that lactation is progressing normally helps her to trust that her milk supply is sustaining her infant. It's very rare for a woman with proper breastfeeding management to be truly unable to provide adequate milk for her baby. Having said that, there are some actual reasons that a mother may not develop optimal milk production for her baby. It's important to note that these occur very infrequently. The vast majority of women who claim they have inadequate milk supply perceive their supply as low when it actually is not. Insufficient nursing or mismanagement of feedings is when the baby is not breastfeeding enough for the mother to develop an adequate supply. If the baby has a poor suck, for example, he may fail to fully empty or sufficiently stimulate his mother's breasts, which in turn result in a lower milk supply. This is easily corrected by educating the mother to nurse more often, at least 8, if not 10 to 12 times in 24 hours. Babies with poor suck should be assessed by the lactation consultant, who can strategize with the mother about ways to improve her milk transfer. Severe hemorrhage requiring a blood transfusion will cause a shunting of blood from the pituitary gland, damaging its function and temporarily causing glandular failure for this birth. Both retained placenta and polycystic ovary syndrome, PCOS, can interfere with hormonal changes that control milk production. Women with hemorrhage or retained placenta are at increased risk for inadequate milk production. Breast surgery can damage the breast tissue or gland. If the nerve carrying impulses to the brain to trigger hormonal releases that control lactation is severed during breast surgery, milk production will not occur. Milk ducts that carry milk to the nipple can also be damaged, severed, or removed during surgery, reducing the amount that can be transferred to the infant. Women who have had breast surgery should be followed closely until breastfeeding is well established. Outcomes vary widely, so it is important to counsel the women regarding how to assess adequacy of supply to their infants and to employ good breastfeeding technique, as some women with a history of breast surgery are able to successfully breastfeed their infants. In very rare cases, mothers might be physically unable to produce enough milk for their babies as a result of insufficient glandular tissue. The picture in this slide represents a woman with underdeveloped glandular tissue. Notice how one breast is significantly smaller than the other. Ask these mothers about changes during pregnancy to help tease out this scenario. They should have experienced breast changes in puberty, such as breast growth and/or during pregnancy. Tenderness, fullness, and darkening of the areola are all positive signs for lactation that occur through the pregnancy. Once nursing is well established, engorgement will generally not occur. Finally, it is important to recognize that some medications interfere with optimal milk production. Ask the mother about all medications, whether prescriptions, over-the-counter, herbal supplements, and recreational drug use. Examples of medications that can interfere with milk supply are antihistamines, which have a systematically drying effect, and alcohol use, which has been shown to reduce milk production. When there is a concern that the baby is not consuming adequate amounts of breast milk, or that the mother is not making enough volume to meet the baby's needs, it's important to determine if the concern is actual or perceived. A thorough breastfeeding history and assessment looking at both mother and baby is needed. A baby needs to breastfeed 8 to 12 times in 24 hours to consume adequate amounts of breast milk for growth and stimulate the mother's milk supply. A baby feeding less than 8 times will often be irritable and not gaining weight well. If a baby is supplemented or given a pacifier to suck on, and not given the opportunity to nurse at breast at least 8 times in 24 hours, this reduces stimulation to the mother's breasts and, as a result, lowers the amount of milk produced. Simply having the mother increase the frequency of nursing at breast and reduce, limit, or stop the supplementation should improve her milk supply. Probing to determine if there's a maternal history of breast surgery or breast changes can help assess the mother's ability for milk production and identify a potential or actual reason for low milk supply. If a mother is using a nipple shield while breastfeeding, this can block the stimulation to the breast, causing a decrease in milk supply, or interfere with milk transfer to the baby. It may also block direct skin-to-skin of the baby's lips on the mother's breast, which reduces stimulation and ultimately milk supply. If a mother who has been discharged from the hospital is concerned that her baby is not getting enough, ask if the baby has been gaining weight. If a baby is gaining weight adequately, then it is not a milk supply issue. Explore other reasons why she thinks the baby is not getting enough. Maybe the mother is expecting the infant to be sleeping through the night, or perceiving breast fussiness is a sign of hunger. If breastfeeding is going well, mothers may experience uterine cramping, leaking of milk from the breast the baby is not nursing from, and/or a feeling of relaxation or peacefulness during breastfeeding from the hormones that are released. Does the mother feel like her breasts are full between feedings? On the day a mother's milk comes in, typically between days 3 and 5, she should feel breast fullness. If she's engorged, it's helpful to assess if the infant is adequately latching on and transferring milk. If breastfeeding is going well, a mother should experience minimal to no breast engorgement. The breast should feel full before feeding, with softening at the completion of the feeding. On rare occasions, some mothers will be so fatigued or experiencing anxiety or depression after the birth of a child that they may not be able to experience a letdown. If you think this may be an issue, the mother should immediately be evaluated for postpartum depression by her physician, with close follow-up and management of breastfeeding by a lactation consultant. Letting the mother know what to expect day by day can help a mother feel more comfortable with breastfeeding and caring for her baby. If you or a mother is concerned about breastfeeding, an assessment and observation of the dyad during a feeding is needed to verify how things are going. Assessment of the latch, suck, and milk transfer is important in evaluating breastfeeding and the infant's ability to transfer enough breast milk for adequate growth. This should be done at least twice a day for inpatients. Following baby's weight for expected progress will allow further assessment regarding whether or not intake is adequate. A baby that is doing well at the breast will suck vigorously when nursing and wake up easily for feeding. If a baby is falling asleep shortly after initiating breastfeeding, assess for a deep enough latch to be able to transfer milk. Often when babies are not transferring milk, their suck patterns are weak and they are sleepy at the breast. Another question to ask the mother is if breastfeeding is comfortable. If a mother is experiencing nipple or breast discomfort, these can often be signs of an improper latch that can lead to an ineffective milk transfer or decreased stimulation to the breast that will result in low milk supply. During observation and assessment of the feeding, listen and observe for swallowing of the milk while the infant is nursing. The room must be very quiet to hear swallowing. Be sure also to assess the infant's output in the last 24 hours to determine adequacy of milk transfer. Remind mothers that breastfeeding exclusively helps to build up milk production and facilitates that the baby will get adequate volume of milk to meet his needs. Providing infant formula and using pacifiers during these critical first weeks interferes with the mother's ability to produce the highest volume of milk possible for her baby. One way to assess that the baby is getting enough milk is to keep track of the number of wet and soiled diapers that get changed in a day. A well-fed baby should have at least 1 wet diaper on day 1, 2 wet diapers on day 2, and so on for each day of life. By day 6 and older, 6 to 8 wet diapers a day is what to expect for a well-hydrated breastfed baby. Infants should have at least 1 bowel movement the first day of life and at least 2 bowel movements each day thereafter. Once the milk has come in, between day 3 and 5, the baby should have plenty of wet and soiled diapers with pale yellow or nearly colorless urine. Usually diapers will be both wet and soiled at the same time. Let the mother know that she might not be able to see urine in the diaper, but that the diaper will feel heavy. Suggest that she put 3 tablespoons of water in a diaper and feel how heavy the wet diaper is. The first stool, called meconium, is a black, sticky bowel movement that has been inside the infant while in the womb. Over the first few days, the stool should change from the meconium to a transitional stool, which is green, eventually to a yellow seedy bowel movement that can be loose and runny with yellowish curds. A well-breastfed baby will have at least 2 of these stools a day, although often the baby will have 1 every time it feeds. Keep your language simple as you help families know what to anticipate. What goes in must come out. Let the mother know she should call her doctor if her exclusively breastfed newborn has less than 1 stool per day, or if her baby is still having meconium stools after day 5 of life. If breastfeeding is going well and the infant is latched deeply at the breast, a change in the suck-swallow pattern can be noticed. When infants first latch on, they start off sucking faster to elicit milk letdown. Within the first few minutes of suckling, once letdown is achieved, the infant's suck pattern will change to a 1-to-3 ratio of swallow to sucks. This is seen once a mother's milk has increased enough in volume, typically after the first 2 days. On day 1 and 2, one may see intermittent pauses of rest between suckling bursts. Movement of the facial masseter muscles can be seen with effective suckling at the breast. When the latch is shallow or weak muscle movement is seen, the suckling pattern looks more like fluttering or quivering of the jaw without wide jaw movements. As the feeding progresses, more swallowing should be heard and seen. Mothers whose milk has come in will often experience leaking during letdown from the breast that the baby is not nursing on. Mothers also typically feel relaxed or peaceful due to hormones of lactation. Some mothers notice a tingling sensation in their breast or thirst during letdown. Some mothers, especially those who have had more than one child, experience uterine cramping. Breastfed infants have often appeared to grow slower than those not breastfed, especially after 3 to 4 months of age. This has been due to older growth charts based on formula-fed infants. More recently, the pediatric growth charts have been revised, and the current version, developed in 2010 by the World Health Organization, is based on the growth of babies that were predominantly breastfed for at least the first 4 months of life, with continued breastfeeding through 1 year of age. These growth charts more clearly represent expected growth and more accurately show optimal growth of healthy children. The fastest growth occurs over the first 3 months of life and slows thereafter through the rest of the infant year. Generally, one would expect infants to gain approximately 1 ounce a day or 5 to 7 ounces per week during the first 3 months of life. Normal growth then slows approximately to ½ ounce a day or 3 to 4 ounces per week during months 6 to 12. We expect a baby to return to birth weight by 2 weeks old and at least double her birth weight by 6 months. Most babies triple their birth weights by 1 year of age. It is important to note that a baby's initial weight often reflects some fluid. This may come from IV fluids given to the mother during labor and also from the previous uterine environment. As a result of this fluid, it's normal to see babies lose up to 10% for a full-term infant and up to 7% for a near preterm infant from their birth weight by 72 hours of life. Be sure to let the mother know that this is very normal and it's not reflective of her ability to breastfeed. A weight loss of more than 7% in the first 72 hours for a full-term baby and more than 3% for a near preemie should trigger a breastfeeding assessment of the mother and baby. Putting the baby to breast more often or offering a breast pump to help increase milk production would be appropriate. Teaching hand expression after breastfeeding and collecting the colostrum on a spoon to feed back would be another strategy to ensure the infant is getting enough milk. A weight loss of closer to 10% from birth weight for a full-term baby and 7% for a near preemie is more concerning to a breastfed infant and requires a lactation consultation, feeding observation, and management, along with support and close follow-up even after discharge. Weight losses above these amounts are abnormal and need further investigation. Close follow-up by the breastfeeding diet is important to ensure breastfeeding success. The American Academy of Pediatrics recommendation is to have a formal evaluation of breastfeeding by a trained caregiver at least twice a day with full documentation in the hospital records during the hospital stay, along with all breastfeeding infants seen by a pediatrician or other knowledgeable and experienced healthcare professional within 72 hours of discharge to evaluate breastfeeding and weight gain in the breastfed infant. When mothers are struggling to learn breastfeeding and feeling the enormity of providing complete nutrition, care, and nurturing for a new baby, they can quickly feel overwhelmed with anything that doesn't go as expected. Your support can provide the assistance that makes the difference for a mother who may otherwise give up on breastfeeding. The knowledge that you share with the mother about her baby will give her the tools to make informed decisions and empower her to feed with confidence. The early days of breastfeeding can be exhausting. Let the mother express her concerns and frustrations so that you can validate those feelings and show her how to carry on. Stating that this is normal will go a long way toward helping the mother to cope. Often, this is all a mother needs to hear in the middle of the night when her baby wakes often to feed in the first few weeks. When all staff members are trained and provide consistent information to mothers about breastfeeding, this reinforces that the information provided is correct. Often mothers will ask different providers the same question to validate the information. Be sure to let mothers know what they are doing right and that it gets easier. Provide information on support outside the hospital for use after discharge. Encourage mom and baby to remain skin to skin as much as possible during the first few days after delivery. The skin-to-skin contact of baby with mother enhances milk production through stimulation of baby on the mother's body. Skin-to-skin care allows baby to adjust to the new environment in a safe place and to suck and feed as often as desired and necessary. It also provides opportunity for the mother to learn her baby's language and needs. Feeding early and often, within the first hours when possible, with no limits on the amount of time the baby spends at the breast, no pacifiers, and no unnecessary supplements, will help ensure adequate milk supply. Rooming in allows the parents to learn about their new baby, the baby's feeding cues and behaviors, and the confidence of knowing where the baby is. Rooming in provides more teaching opportunities with caregivers and parents. Research shows that mothers get better rest when the baby is in the same room with them. Hand express colostrum so the baby can have more. If baby is initially not feeding well, doing so will improve the mother's milk supply. Ensure a good latch and identify and resolve latch and positioning problems as soon as possible. Teach parents normal newborn reflexes and behaviors. Knowing what baby's behaviors mean will help parents feel confident and better able to care for their baby. Let parents know that most babies have their days and nights switched, and in the first few weeks will often have longer and more frequent feeds at night. Reduce distractions and interruptions. Well-meaning visitors can interfere with the establishment of breastfeeding and identification of feeding problems. Encourage the parents to consider requesting privacy in the hospital. Suggest ways family and friends can be supportive without requiring frequent visits to the hospital or home in the first few weeks. Improving milk intake and maximizing maternal production of milk are critical in the initial days after delivery. Improving or correcting breastfeeding issues before a mother goes home from the hospital is important and easily done while keeping mother and baby together during this important time. Intervention should be appropriate to the suspected causes of inadequate milk supply. To help increase milk supply more quickly, increase nipple stimulation through improved latch, massage, and hand expression and/or pumping. Hand expression is a critical skill to teach all breastfeeding mothers before discharge from the hospital. Breastfeeding routines should include frequent feedings and follow-up contacts with the healthcare provider or breastfeeding specialist after discharge from the hospital. Breasts are two of the same organ, but they function independently. It is normal for one to produce more milk than the other. An infant that nurses more frequently or longer on one breast will cause that breast to make more milk. Milk changes over the course of a feeding and over the course of 24 hours. It is always changing to meet the baby's growing needs. Foremilk, or the milk at the beginning of the feeding, has a higher water content and quenches an infant's thirst, whereas the hind milk, which comes toward the end of the feeding, is higher in fat and satiates the baby, making him feel full. If a baby is removed from the breast before he gets to the hind milk, he may have a slower weight gain or wake more frequently for feeding. Encourage the mother to always allow her infant to finish nursing one side before offering the next. Teach the mother to watch the baby, not the clock. More frequent feeds provide more fat. If the infant feeds frequently for a 3 to 4 hour stretch, called a cluster feeding, he is more likely to sleep for a longer stretch after the feeding. Empty breasts fill faster. Ensure the baby finishes the breast before switching to the other side. Milk left in the breast sends the message to downregulate the milk supply, so the breast makes less milk. The breasts work on a supply and demand basis. They will only make the amount of milk that is removed. Recommendations by both the American Academy of Pediatrics and the World Health Organization are for women to breastfeed exclusively for 6 months. Both the American Academy of Pediatrics and the World Health Organization concur that solids be started at 6 months of age, with continued breastfeeding thereafter. Initial food should not replace breastfeeding, but instead be a complement to breast milk. The American Academy of Pediatrics recommends breastfeeding continue for at least a year and as long as desired beyond that point by mother and child. The World Health Organization, by contrast, recommends women breastfeed for at least 2 years. Breastfeeding should not be discontinued until the child is able to eat enough fat and protein from foods to replace the breastfeeding, which does not usually occur for most babies until they are older than a year. Several factors can influence milk production. Common obstacles to optimal milk production are pacifier and nipple use before breastfeeding is well established. When infants are given pacifiers, feedings are often missed due to time spent sucking on pacifiers. The Maryland Hospital breastfeeding policy recommends that breastfed newborns not be given pacifiers while in the hospital after birth. Giving healthy term newborns pacifiers while still in the hospital has been associated with stopping of breastfeeding before 6 weeks of age because of the association with poor latch, decreased milk production, low weight gain, and earlier weaning. When unnecessary supplements are introduced, the infant is overfed, sleeping longer, and not waking frequently enough for milk synthesis and supply regulation. Research has shown that if nipples and bottles are used to feed a supplement before breastfeeding is well established, the nipple can interfere with the infant's ability to establish an effective latch for milk removal. Current recommendations by the American Academy of Pediatrics is to wait at least 4 weeks until breastfeeding is well established before introducing a bottle or pacifier nipple. If supplements are needed, the first choice should always be a mother's own breast milk, fed using an alternative feeding device that is approved for use with breastfeeding infants at your facility. Research has shown that infants who are rooming in 24 hours a day have higher success rates with breastfeeding. Hospital routines that remove the infant from a mother's room to perform procedures, exams, or allow mothers to rest often cause delayed or missed feedings. Once feedings are missed, a cascade effect can start to occur that can undermine a mother's success with breastfeeding exclusivity. A 2009 study in the American Journal of Public Health reported hospital practices that conflicted with the World Health Organization UNICEF 10 Steps to Successful Breastfeeding, including supplementation and pacifier use. In hospitals that practiced 6 or 7 of the 10 steps, mothers were 6 times more likely to achieve their intention to exclusively breastfeed than those in hospitals that practiced 0 to 1 of the steps and where mothers had reported that their babies had supplementary feeds. The authors recommend that hospitals should implement policies that support breastfeeding with particular attention to eliminating supplementation of healthy newborns. New mothers and maternity staff need to learn the delicate breastfeeding relationship between mother and infant that needs to occur in the critical first few days in the hospital to establish breastfeeding. When mother and infant are kept close together, the mother learns her baby's feeding cues and needs. Babies are given unrestricted exposure to their mother's breasts immediately after birth, instinctively learn how to breastfeed without needing hospital staff interventions to latch. Hospital staff can improve breastfeeding by removing obstacles and allowing mother and baby to stay together. Staff routines and procedures can be adapted to be performed in the mother's room instead of in the nursery to allow the infant to remain in close contact with its mother. Procedures like blood draws and physician exams done in the mother's room save time and allow for teaching at the same time. The healthcare industry is moving in the direction where reimbursement is based on the quality of care. As a result, we must begin to meet the regulations and standard of care based on scientific evidence. The World Health Organization 10 Steps to Baby Friendly is recognized worldwide as the best practices to implement when achieving quality care for breastfeeding mother-baby dyads. In helping hospitals to achieve this level of quality care, the following is recommended: implementation of early and ongoing skin-to-skin contact, early and frequent feedings, night feedings, water or formula supplements for medical indications only, 24-hour rooming in with limited separation of mother and baby, teaching mothers about infant behavior, lactation management, and feeding cues, education of staff and providers on advantages of breastfeeding and lactation management, as well as hospital routines that facilitate breastfeeding, and establishing community support groups to support mothers once discharged. Doing so will not only meet the 10 steps to successful breastfeeding, but also meet the changing requirements needed for future hospital reimbursement and Joint Commission accreditation. You are the key to mothers' successful breastfeeding in the hospital. Only by establishing successful breastfeeding in the hospital can we set mothers on a path to succeed with breastfeeding after discharge. Do not doubt the importance of your influence on the mother's breastfeeding outcome. You have knowledge and skills that are important. Breastfeeding support is a valuable part of your work with mothers and newborns.